Today we have a very young author, lead author, and she is Dr. Isha Anwar, who's just a house surgeon. Very, very impressed. In the Department of Medicine at Sri Siddharth Medical College at Tumkur in Karnataka. And we have our very dynamic president-elect of IJCCM, Dr. Srinivas Samavedam, the chief intensivist of the Department of Critical Care Medicine at Ramdev Rao Hospital, who wrote the editorial for the article which Isha and her colleague, Dr. Darrell, published. So I'd start off by asking Isha that why did you want to choose this topic and how did you come across this topic specifically?
At a particular night duty where I was the house surgeon posted for, there were around 4 to 5 chest pain patients that had come in within 1 hour. So it was getting hard for us to find out as in who should we first attend to. So the same thing was discussed the next day with my associate professor of the emergency department. And he had informed us about this hard score, and we found this topic as an interesting topic to move forward with, to publish a paper or go on further to see what else we could find out of.
Mm-hmm. So can you just quickly tell us what are the components of the hard score? I mean, I know it's all there in the paper, but just quickly.
Yeah. So the hard score, which is the abbreviation of history, ECG, age, risk factors, and troponin I, it's a score which helps risk stratify patients, and also it gives us an accurate measurement of MACE occurrence. MACE is major adverse cardiac events. So the major adverse cardiac events include occurrence of MI, or death, or if there's a requirement of coronary revascularization.
So then you conducted the study and you found that it is quite a useful study. Is that right?
Yes. So when we conducted this study, we got to know that most patients who had a high risk score. So a high risk score would be something above 7. The total score is around 10. So 1 to 3 would be considered low, and 4 to 6 moderate, and 7 to 10 is basically high risk scoring. So most patients in our study, out of 200 patients, 52 patients, which is 81% of the population of high risk scores, ended up with having myocardial infarction. And our sensitivity and specificity was also very high, and our area under the ROC was around 0.97, which is again a high score. So we found out that by giving each category for the patients, we could either give them an early discharge or send them further. In our hospital, we have a cardiac care unit.
So basically you could triage them correctly. That's what you can.
Yes, we can triage them correctly, and it's very useful for interns, junior doctors to do this, because we don't have in-depth knowledge of the subject to immediately decide what to do. So at least we can alert higher authorities for it,
Yeah. So Dr. Srinivas, in your editorial, you have extensively reviewed all the other scores. So would you like to tell the viewers about these scores?
Yeah, so I think this was a fantastic initiative by this young team from Tumakuru. And what exactly happens when you have these patients is most of the first responders or the people who first see the patients in the emergency room cannot decide whether this patient can be discharged home or has to be admitted in the ward or should be in an intensive care unit. Now, that's where the dilemma comes, and that's where I think this hard score helped them simplify the decision-making process. So the global registry for acute cardiac events also has a similar score, which will, however, identify patients who will develop major complications of acute myocardial infarction. And for those patients who actually undergo an invasive angiographic procedure, The TIMI score will tell us who will actually improve with a good revascularization and who will end up with cardiogenic shock according to the different strategies. So when you apply a combination of these scores in the emergency room and in the post-cath ward, you will be able to clearly pick up those patients who don't need to utilize your ICU and emergency room resources and stretching the already taxed burden of trust and teaching hospitals. At the same time, you don't do you won't be too casual in sending the borderline patients home. You would still put them in the observation in a semi high dependency unit, maybe do repeated ECGs, look at enzymes again, so that you don't miss those outliers who don't declare themselves as acute coronary syndrome. So my understanding and why I chose this article for the editorial was that it brings into the idea of using simple bedside clinical and simple screening tools to optimize your resources, to not to deny the deserving patients the highest level of care, while at the same time not overdoing things and putting everybody into the intensive care unit and taxing the doctors, the nurses, and the healthcare system overall.
Very nicely summed up. I think that really gives an excellent overview of what the score is all about. Taking that argument a little forward, do you think it has any application, Dr. Srinivas first and then Isha, in the ICU also?
See, you get a lot of perioperative patients, right? You get into the ICU. You get patients who come with non-coronary diagnosis into the ICU. For example, a pneumonia, for example, who's on non-invasive ventilation, there is hypoxia and maybe a little bit of hypotension, for which you start a norepinephrine infusion. And these patients can have chest pain from anything. They can have chest pain from just by lying in the bed. They can have chest pain because of the coronary insufficiency that is triggered by vasopressor support, anything. So some adaptation of these scores can be actually brought to the bedside, even to the point I would say the senior nurses who are at the bedside should be trained in applying these scores so that, as she said, alert the people who are supposed to be paying attention to these patients. Suppose you have a 30-bed ICU at 2 a.m. in the morning. The senior on the floor is not expected to be monitoring everybody for symptoms and signs. But if a smart nurse, an intern, a first-year postgraduate trainee can be taught these scoring systems, I think we will be able to pick up these even in the intensive care unit, surgical intensive care, for example, trauma units, for example, obstetric units, for example. I think we can broaden the usage of this score, say, instead of saying limit this only to emergency room settings. It's a learning point I felt when I read this article.
Excellent. Dr. Isha, you want to add anything to that?
Yeah, as Sir said, that it can be applied other than only in the ER in other we have a cardiac care unit too, right? So it's only a 10-bed cardiac care unit. So in case we need to discharge a patient into somewhere else and give space to a patient who actually needs that bed, that is what I think would be useful by using this scoring system. And as well as other than only doctors using it, I feel like it's an easy to use system for nurses and head nurses as well as interns. I feel that it could benefit very well, and it can easily save lives and help reduce the bed shortage system in our country.
Excellent. Would you like to highlight any other aspect of the study? We are almost.
What I would like to say in conclusion of the whole study that we did is, apart from only looking at high-risk patients, we are also helping save costs for low-risk patients instead of sending them unnecessarily to further testing, and or also we can alert them and give them if they're moderate risk patients, we can alert them to maybe look after themselves and take care further, or and low risk patients are who can't afford certain testings are forced to do certain testing. So if we categorize them, I feel like we can benefit the patient population.
Right. And any downside of this score, Dr. Srinivas?
Yeah, so despite the high predictive value of the scores and the good AUROC of this curve, it probably 10 to 15% of patients who should be discharged home will still end up staying in the hospital. But I think that is a small price we pay for not missing those patients who would have significant coronary disease, go home, have an arrhythmia, and die. So I think that from that perspective, we should not see this as a drawback. But yes, it will result in a little bit more patients actually staying back in the hospital.
So as we always say for screening tests, they should have a high sensitivity,
Yeah.
but the specificity may not be so
Yeah.
great. So I
Yeah.
think that's the most best part about the score. And
Yeah.
I would ask you to leave the viewers with a take-home message, both of you, each one of you, maybe Isha first and Dr. Srinivas then.
So this scoring system may not completely replace decision making, but it's obviously going to help the doctor make decisions and upgrade the decision making. I think the final power lies in the doctor's decision, because every patient is different and has their individual. There are exceptions to this scoring. So we're keeping that in mind. I think we should implement this and make it a uniform system in our country.
Thank you, Isha. Dr. Srinivas.
I have two messages. One for all the people who are listening to this podcast. One is we need not have high funda gadgets and equipment and tools to make it, to use certain things and common clinical tools to make a difference to patient care. That's the biggest message this study has given us. My message to the two investigators is don't ever lose this motivation, this spark, and this enthusiasm of doing studies. You have a long career ahead. Somewhere along the line, you will be say, "Kya karna hai?" Don't get into that mindset. Keep doing this. I'm sure you will do fantastic.